So what I will dedicate during this presentation is a discussion on how do we select potential patients for clinical trials with microsatellite stability for immunotherapy. And even though there is no great biomarker signature on the tissue, is there potentially a clinical signature that suggests that a patient could respond to checkpoint inhibitors, although they have microsatellite-stable colon cancer? The other thing we will discuss today is how do we improve on PD-1 inhibition in MSS-CRC, and within that population that could potentially benefit from immunotherapy with microsatellite stability, does the addition of CTLA-4 inhibition improve on PD-1 inhibition in metastatic colorectal cancer? So this paper in 2020 was actually our first publication on microsatellite stability and the potential impact of site of metastatic disease on response rate. This work was in follow-up to a Japanese trial, the RIGO-NIVO trial, which looked at regorafenib nivolumab, and at that time was presented at ASCO, and really kind of stirred the pot that immunotherapy could work in MSS, because that study showed that patients with microsatellite stable colon cancer can respond to regorafenib and nivolumab, and really many of us in the United States, based on that study, started offering this combination off-label to patients with microsatellite stability. And when we looked at our initial experience with regorafenib nivolumab in 18 patients highlighted here, we noted that only 5 patients had stable disease out of 18, and the other patients all had pretty much progression. And all the patients with liver metastases really did not benefit. And 4 out of the 5 stable disease were without liver metastatic disease. And many of those had minor shrinkages. And so in our mind, we started thinking that, hey, there must be something different about liver metastases that make it more resistant to immunotherapy. And perhaps if we look at site of metastatic disease, we could identify a group of patients with colorectal cancer who could benefit from immunotherapy. So that was basically our hypothesis. And obviously we are a research center and we enroll a lot of patients on immunotherapy clinical trials. And so we did a retrospective analysis of a large patient population in our center that had microsatellite stability and had received either a PD-1 or a PD-L1 inhibitor under a clinical trial. And all these patients had progressed from prior chemotherapy. And these clinical trials did allow PD-1 or PD-L1 plus another agent, but not chemotherapy. And we looked at the impact of ECOG performance status, tumor location, KRAS status, etc., molecular diagnostics, as well as the site of metastatic disease on response to immunotherapy. And we published this work in JAMA Network in 2021. And what you can see on this slide is that the progression-free survival in patients without liver metastases was, pretty decent, about 4 months. But those patients with liver metastatic disease, pretty much most of them, progressed by the 2 months mark. And this difference in progression-free survival was statistically significant. Now, we went further and asked the question, well, do patients who had liver metastatic disease, who had surgery with resected liver metastases, could they benefit also from immunotherapy? And that's the blue line that you see on the right side of the slide. You can see that, yes, the progression-free survival on PD-L1 or PD-1 inhibitors plus other investigational agents is, pretty good in patients with resected liver metastases. And neighbors, the one that is, the one in patients without any evidence of liver metastases at any point, and is statistically superior to those patients with active liver metastatic disease. So our findings suggested that active liver metastases is a strong biomarker of resistance to immunotherapy. So meanwhile, I had led the prospective phase 2 clinical trial of regorafenib nivolumab in the United States, and on that study we enrolled about 70 patients, and these patients received regorafenib Stivarga 80 milligrams daily, 3 weeks on, 1 week off, along with nivolumab at 480 milligrams intravenously once every 4 weeks. These patients included patients who had progressed on all standard chemotherapy, but obviously did not receive prior regorafenib. And when we looked at the objective response rates in patients without liver metastases, again, regorafenib, nivolumab, regorafenib alone has 0% response rate or 1% response rate in patients with metastatic colorectal cancer. Nivolumab alone is also expected to have, almost 0% response rate. Here you see that 20% of patients or 21% of patients without liver metastases, 5 out of 23, had an objective response rate. And out of 47 patients with liver metastases, none of those patients had a response, none. And if we look at the progression-free survival, it was 3.5 months for no liver metastases, 1.8 months for liver metastases. Again, suggesting that there's something different about the response to immunotherapy between liver and non-liver metastatic disease. This slide shows the waterfall plot, the spider plot in patients without liver metastases, and you can see in patients without liver metastases, the blue is the partial response, and some of these partial responders continued beyond a year. Okay, and on the other hand, liver metastatic disease, no objective response, and most of these patients had a early termination of treatment because of progression. So great. How does our findings, correlate with other findings in the literature? I think the best validation should come from a randomized phase 3 clinical trial. And here I'm showing you the data from the LEAP 017, which is a large phase 3 clinical trial recently published in JCO. Looking at lenvatinib plus pembrolizumab, so PD-1 inhibitor plus a TKI inhibitor targeting VEGF-R, and that was compared to regorafenib alone, or trifluridine. And unfortunately, this study, even though it showed a little trend of superiority of lenvatinib pembrolizumab, was actually a negative clinical trial. And lenvatinib pembrolizumab is not approved for microsatellite-stable colorectal cancer. But what is interesting in this study is that when you look at the outcomes of patients based on involvement of liver or no involvement of liver at the time of initiation of therapy, you can see that patients without liver metastases, the hazard ratio strongly favors lenvatinib pembrolizumab for overall survival, for progression-free survival, and actually this is response rate and for overall response rate. So note here that lack of liver metastases was associated with 17.7% overall response rate with lenvatinib. The difference in overall response rate is 17.7% with a the response rate was 17.7% in the group receiving lenvatinib pembrolizumab. So clearly there is a benefit here in the non-liver metastases, but unfortunately this study was not really powered enough to answer the question for this group, and hence there will be no approval for non-liver metastases for lenvatinib pembrolizumab. So then the next question is, are all non-liver metastases created equal? I mean, can we really separate patients without liver metastases and say, hey, you whatever your met is, whether it's peritoneal, whether it's lung, whether it's bone and brain, doesn't matter, you're going to respond to immunotherapy, and only if you have liver metastases you want. And so the answer is no. And not all non-liver metastases are created equal. And we looked at that question. We looked at 96 patients in our practice that we treated either on regorafenib nivolumab or regorafenib ipilimumab nivolumab, a regimen that we have developed here at City of Hope. And to kind of avoid the bias of taking patients off study and to look at an organ-specific response rate, what we said is, let's look at all patients treated with these combinations and look only at the 2 months mark and look at the objective response rate at 2 months and isolate each organ separately and say, let's take a look at each patient's target lesion in the lung and see if it responds or not target lesions in the liver, do they respond or not? So this is an organ-specific response rate, which has not been done previously in the literature, but we decided to do it to understand better the impact of organs on response rate to immunotherapy. And we found something very interesting here, that when we isolate lung alone, 72 patients with lung metastases, and some of these were lung only, some with lung and liver, etc. But if you look at only the lung lesions at 2 months, 25% of patients, the lung lesions shrunk by more than half. And about half the patients at 2 months, the lung lesions were stable. Now, if you look at liver, 0%, okay, at 2 months had a response. Now, what is also very interesting when we look at lung, the response rate in the lung lesions is different if it's lung-only metastases versus if they had lung and liver. If they had lung and liver, only 7%, had shrinkage in the lung mets, major shrinkage. But if they had lung only, about 56% had major shrinkage. So we believe that the biology is different if you have multiple organ involvement, and it is possible that the liver metastases also are immunosuppressive in general for the whole body. But the group of patients who had the best outcome are the lung-only metastases. As you can see, 56% of those patients had an objective response at 2 months. Now, if we look at best overall response rate, meaning as you continue these patients on treatment, what's the best response? Any lung involvement, because a lot of these patients include, lung plus liver, etc. Overall response rate is 22%, disease control rate is 70%, and any peritoneal involvement, response rate 0%. So site matters, right? And so we went further to understand a little bit better as to, not only impact of liver versus non-liver, impact of peritoneal versus non-peritoneal. And so here you can see very similar curves as far as the very poor progression-free survival for any liver metastases to immunotherapy and any peritoneal disease without liver mets. So there's no confounding here. We've chosen any peritoneal involvement had a very poor progression-free survival compared to no peritoneal, no liver. So we do believe that the site of metastatic disease pattern, the site of metastatic disease matters. And we took this to the next step. We really need to understand why. Why does lung metastases respond better than liver metastases, better than peritoneal metastases? So, we do take patients for curative intent surgeries, right? So if a patient has a hepatectomy, you have those specimens. If a patient had resection of lung metastases, you have those specimens. If you have a patient who had cytoreductive surgery for peritoneal disease, you have those specimens. And we have primary tumor. So we decided, let's take a look at those specimens, even though these patients did not get immunotherapy, to understand, is the tumor microenvironment different? And indeed, what we have done is we looked at the metastasectomy samples, and we divided it into what we call the core of the tumor and inner core, and that's this part of the tumor here, and surrounding the core inner, the core of the tumor, we have the inner. This is the inner core, and this is the outer core, and this is the juxtamembrane. Okay, and this is the distal area, and we wanted to see, do the immune cells expression differ in the core, inner membrane, outer membrane, and juxtamembrane, and distal part around the tumor between liver mets and lung mets and peritoneal mets and primary tumor, right? And we did multiple panels. This is called multiplexing. So you get all these images, but what we're doing here is we're doing immunohistochemistry on different biomarkers of immune cells, and we're overlaying them on the same slide. And so these are the cancer cells and immune cells, and these are the biomarkers that we looked at. So CDK20, obviously, to find the cancer cells. And there are different biomarkers here for macrophages, T cells, memory cells, etc., antigen-presenting cells. And we compared liver versus lung versus peritoneum versus primary. And one thing that was very interesting here is that when we look at the liver, okay, and particularly if we look at the core of the liver, you do not see any CD8 or CD4 infiltration. So look at the inner core of, or the core of the tumor in the liver. There's no new cells. There's nothing like the lung. Lung has all these very bright white dots, which are CD4s. You also see some CD8s, which is a little bit greenish. You don't see that in the inner part of the tumor of the liver. In the colon, the primary tumor, it's very similar to the lung. So the primary, and we know that immunotherapy with MSS, based on the niche 2, based on NEST and others, even MSS, they respond to immunotherapy combinations. Liver does not. And lung, it does respond. Liver does not. So lung is very similar to the primary. Liver is not. And if we look at the peritoneal disease, also they are impaired, okay? They're not as good as lung. You don't see that great infiltration within the tumor itself. Again, pink is tumor. And within the pink and inside, not much. And however, when you look outside in the membrane, there's really not that big of a difference. So we have an impairment of infiltration of lymphocytes within the inner aspect of the tumor in liver metastases. It's a mobilization problem. Now, you give checkpoint inhibitors, if there's no lymphocytes, they're not going to be working. They're not getting into the tumor. So, this is another, patient and again, showing the same thing. Lung in the core, great infiltration. Liver, not much of infiltration. In the primary, great infiltration. All right. Peritoneal, not as much infiltration as lung, but a little bit better than liver there. So we also asked the question about antigen presenting cells. Same situation. Within liver, not as much as lung. Lung very similar to colon. So basically, what we are seeing is that the situation is a antigen presenting cell difference as well as CD8 difference, and the results from our laboratory findings suggest that lung mets show the highest immune activities, and therefore that's why we're seeing the best responses with immunotherapy in MSS patients in lung metastases, but liver is not. And peritoneal metastases have an increased cancer-associated fibroblasts, which is not really good for immunotherapy. And they had a little bit more PD-1 expression. But, I think there's a good rationale why liver and peritoneal metastases do not respond to immunotherapy. That's the bottom line. Now, the next part of our talk here is to talk about, hey, what if we had a CTLA-4? Well, we've done that. We've moved CTLA-4 plus Rigo-Nivo. As I said, we've developed regorafenib nivolumab in the United States, and we've added to it here ipilimumab to see what happens if you have dual checkpoint inhibitors. And remember, regorafenib is good because you have VEGF suppression through VEGFR, and there's some data that it has some suppressive effect against Tregs, and that's why you see the synergy with TKIs and PD-1s. But here we've added CTLA-4 as well to get even more immune activation. So this is a phase 1 expansion trial. We ended up enrolling about 39 patients on this trial. We published this in JAMA Oncology. And indeed, what we saw when we look at our regorafenib ipilimumab study versus Rigo-Nivo that we did on a separate phase 2, we augmented the response rates in non-liver mets to 36.4%. We augmented the PFS to about 6 months when we look at iRECIST, 5 months with RECIST. And on the other hand, with, the numbers were, as I mentioned earlier, inferior on Rigo-Nivo. So that does suggest that adding ipilimumab, a CTLA-4 inhibitor, does help MSS-CRC. And more recently, we published our updated analysis. This is about 5 years after we started this clinical trial in European Journal of Cancer. And very exciting and interesting. If you look at patients without liver metastases, you can see that the progression-free survival plateaus. Here we're talking about almost 4 years from starting this trial, and you've got about 4 or 5 patients who have not progressed. And many of these patients had stopped because the study stopped treatment at 24 months. These patients have not received other therapies. So the PFS by RECIST was 5 months, but there is a tail to the curve. You're getting some very durable responses, very similar to what you see with MSI high CRC. And look at the overall survival. Chemo-refractory patients, overall survival 27.5 months if they are non-liver metastases treated with regorafenib, ipilimumab, nivolumab. Now, these are real responses. These are slides from patients. Those were the patients who were at the tail of the curve. This is a patient who had extensive disease in the pelvis. These are all biopsy-proven mucinous adenocarcinoma, MSS, BRAF, V600E patients who progressed on all lines of therapy, including BRAF inhibitors. And look at the response before regorafenib, ipilimumab, nivolumab, and after. A complete response. This is scar tissue. She had multiple lung metastases. One disappeared. This patient has been now off regorafenib, ipilimumab, nivolumab for 2 years. Circulating tumor DNA is negative, tumor markers negative, no evidence of disease. Probably cured. This is another patient, multiple lung metastases. You can see 1, 2, 3, 4. And actually, she had about 12 lung mets. And you can see that these pretty much resolved. Some of them have only a little scar tissue left. And this patient also 2 years off regorafenib, ipilimumab, nivolumab, circulating tumor DNA by Signatera is negative, tumor markers negative, no evidence of progression, 2 years treatment-free. That's another patient who had multiple liver mets that were resected, hepatic arterial effusion, adjuvant therapy, recurred with multiple retroperitoneal metastases, as you can see, calcified with treatment, or completely regressed. So before, look at this large retroperitoneal metastasis, calcified, this one gone, this retroperitoneal metastasis gone. And again, this patient, after almost 3 years, we kept him on Rego-Nivo after Rego-Ipi-Nivo for another year, and then we stopped about a year ago. Continues to be ctDNA negative at this point. No evidence of activity of his cancer. It does not qualify for a complete response because you can still see the calcified lesion, but biomarker-wise negative and off treatment. This is another patient with an isolated bony met that was radiated, and the radiation controlled the bony met. The bony met still has some activity. This patient had 2 years of Rego-Nivo Ipi, then maintained only on Rego-Nivo at this point. And you can see before on the left, after on the right. This lung met, small lesion. This one, very small lesion now. These 3 have disappeared completely. And, he still has, biomarker positive. And so he's not a CR, but dramatic response. So these are the kind of responses we saw at the plateau of the curve. This is, in my opinion, high-level evidence that immunotherapy works in non-liver metastases. So, I think where is the field going? Now we've got, better CTLA-4 inhibitors. So botensilimab is a drug that has been developed by Agenus Bio. It is what we call an Fc fragment engineered CTLA-4 inhibitor. It is more effective in eliminating Tregs, more effective in activating innate and adaptive immune response. And when this CTLA-4 inhibitor was combined with PD-1 inhibitor, namely balstilimab, without regorafenib, without lenvatinib, without any TKI, without VEGF-A inhibitor, for the first time ever, just only combination CTLA-4 PD-1, you see a big difference in outcome, again, in patients with refractory colon cancer. Look at the liver metastases, just like our curves. They progress at the 2 months mark. That's the red, okay? But look at no history of liver metastases. That's the black line. Look how they plateau, right? Again, similar to the curves I show you with the RIN. About 20% to 25% of these patients have a very durable benefit, okay? And you can see the overall survival, the best in patients without liver metastases or with resected liver metastases. So that's the green line. And, you're also looking at the no history of liver metastases, which is the black line. So those patients do the best. The overall response rate here, 22%, PFS 4.1 months, OS is 20.9 months. So again, very similar to our smaller study, but I think what's nice about this study, it's a very large trial. They treated almost 100 patients on this study. Our study was a lot smaller, and this really is a proof of principle study. Now, there are other compounds out there. ADG126 is a safe body CTLA-4 inhibitor. Again, this is an Fc fragment engineered, but it's activated within the tumor. Not as big of a sample size, but you can see here with ADG126 that they are reporting similar activity in non-liver metastases, and they validated our findings in peritoneal metastases. So no liver, no peritoneal metastases here. Small cohort of patients, 17. Overall response rate is 24%, okay? And disease control rate is 88%. And you look at the waterfall plot here, you can see that, the patients without peritoneal metastases receiving 10 milligram Q6 week and is blue. The higher dose, 10 milligram without peritoneal metastases, is the shaded, is this actually should be Q3 weeks. You see the responses. The green is the 10 milligram Q3 weeks without peritoneal metastases is the highest response rate. So the green, non-shaded solid, is 10 milligram Q3 weeks. That's I think the recommended dose, and that's where you see the best responses. So I think CTLA-4 makes a difference, okay? And I think now you have multiple studies, including ours, that show that CTLA-4 plus PD-1 does result in durable responses in patients with MSS-CRC. Liver metastases, we haven't cracked that yet. I think peritoneal disease, not clear yet that we can tackle that, especially diffuse carcinomatosis. I think if you have isolated few lesions, oligometastatic, you may still see responses with peritoneal disease, but ascites with diffuse peritoneal disease, very hard to crack still. I think we need to have further characterization in the non-liver, non-peritoneal metastases patients as to, is there a tissue biomarker that really identifies further the super responders, all right? Because that will really be how you move the field further. And I think we need to identify more novel drugs besides CTLA-4 and PD-1 for the patients with liver metastases and diffuse peritoneal disease. So with that, I will end, and I'm happy to take any questions.
Perfect. Thank you very much, Professor. I see that we already have a question from the audience. Maybe you can see it also in the section of Q&A.
Yeah, I see that.
Mm-hmm.
Well, does it mean or liver? So when we say treat, it's not chemotherapy, okay? So I think there's a lot of questions related to chemotherapy. Here we're talking chemotherapy and immunotherapy. Here we're talking about immunotherapy without chemo, right? I mean, we're not saying that we should not look at chemoimmunotherapy regimens, because that's a different question, right? I mean, there are other studies like the TRIBE trial, the TRIBE ATIZA, which suggests that there's slight benefit even in the liver metastases when you add atezolizumab to FOLFOXIRI-BAP. But when you're looking at patients with refractory disease and we're looking at immunotherapy alone, active liver metastases, meaning present liver mets on CT that are not resected, should not, in my opinion, be, offered immunotherapy. It's not approved anyway for any patients with MSS right now, but there the likelihood of benefit is small, all right? And I think CTLA-4 PD-1 combination is unlikely to yield any benefit, whether it's ipilimumab, nivolumab, or even whether it is botensilimab, balstilimab, and those patients should be investigated on clinical trials. But if you have somebody with lung mets and liver mets, and say he had two, metastases on the right lobe of the liver, and you did a hepatectomy, and the patient has only lung mets, or a patient who had two small lesions that were ablated, and 6 months later there's only lung mets, I think that patient could respond to immunotherapy. And I think all these should be done, honestly, on prospective clinical trials. This is not standard of care today. So all these are nice signals that we're generating, but it require more validations and FDA approval. So I hope that answers question number one. But yes, I would not treat off-label with the Rigo-Nivo Ipi a patient with liver metastases. And if I had access to botensilimab, balstilimab, I wouldn't offer it to a liver met patient treated with prior chemo, even if it shrunk. I think that the patient should have no active metastatic disease. Does the liver microenvironment turn immune suppressive only when primary tumor is from the colon, or is it also true for primary site of tumor is different? Okay, I think in general, liver metastases are less responsive than non-liver mets, okay? Because that data also exists for melanoma and non-small cell lung cancer. If you look at melanoma and non-small cell lung cancer, yes, liver mets can respond to immunotherapy, but the responses are lower than non-liver mets. And so I think the liver metastases in general have a worse tumor microenvironment, but there are different shades to that resistance to immunotherapy. And for MSS-CRC, that resistance is very strong. But I do believe that it will apply also to pancreas. And anecdotally, we know of some pancreas cancer patients who had non-liver metastases who responded to immunotherapy. But I don't think you would expect immunotherapy alone to respond to metastatic disease of pancreas origin in the liver to respond well to immunotherapy in the MSS setting. Considering the third question is, considering the growing understanding of DME and MSS, what do you believe is the optimal sequencing of treatments? Should immunotherapy combination be reserved for later lines? And is there a potential role for earlier? Yeah, listen, this is a great question, and it's a research question. We are interrogating in our center moving botensilimab, balstilimab earlier in the management of microsatellite-stable colorectal cancer. We have a clinical trial of FOLFOX bevacizumab in combination with botensilimab and balstilimab. We will be presenting data at GI ASCO, so please stay tuned, and the data will be presented in January. But I do think that since we're seeing a signal in those patients with refractory disease, it does make a lot of sense to look at chemoimmunotherapy combinations, but it has to be done prospectively to understand better the toxicity, safety, and understand better the risk-reward balance of moving IO into earlier lines of therapy. There are other groups, like the Italian group, that is looking at biomarker-driven addition of atezolizumab to FOLFOXIRI bevacizumab, and in that setting, they are only including patients with immunoscore positivity on that particular trial. And there are, I think, other studies in development looking at FOLFOX or XELOX plus PD-1 versus plus bevacizumab versus XELOX or FOLFOX plus bevacizumab. So the field is moving, and in those studies, they're not excluding liver metastases, which is good, but they're stratifying for such, which really helps to understand better if you could actually overcome some resistance by moving, checkpoint inhibitors plus anti-androgenic inhibitors plus chemo earlier in the treatment of MCRC, MSS. One question was, why is lung more immune permissive? Why is liver not so immune? Listen, so that's the billion-dollar question. If we knew what's making the liver metastases more exclusive of infiltration, one could potentially develop drugs to overcome that. I don't think our group has an answer to that at this point, and I'm not aware of any publications that have really mechanistically fully explained how that happens. But that is key in developing drugs in the future and overcoming that resistance. And there's a question from Sean Krishnan. I think that's the same question that I just addressed. So I think that's all I have. Thank you for having me today, and I hope all of you enjoy the rest of the meeting.
Thank you, Professor. Great. All the best.
Thank you. Have a good day.
Bye.
Bye.
So we heard a great talk from Professor Fakih about MSS and the role and I would say treatment and the challenges in giving them immunotherapy and all the combinations. Now, with these two lectures, I would like to conclude and to finish with this session. It was great. We heard a great two lessons about very hot topics, and I do hope that you will in the future give us maybe more answers. All the best, all. Bye.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.